Understanding growth is one of the difficult topics in POS. So I'm choosing a wrong time to explain this post lunch. But it may probably keep you awake if you pay attention. That's why I've chosen a difficult topic. The most complex issue is to reduce the level of our kids' differential horizontal growth. These slides also are self-explanatory. Feel free to take a picture of the slides. The power part is taken from G7 seminar 4. You have this PowerPoint in there. The growth of maxilla and mandible from the time the child is born until maturity happens in all dimensions. But what we are interested is in the AP dimension. In the AP dimension, mandible grows more than the maxilla. That's the skull of an infant, that's the skull of an adult. If you notice the skull of the infant, you don't even see the mandible. Versus an adult, the mandible is nice and prominent. That shows how much the mandible grows more in relation to the maxilla. There are some people who are horizontal growers, vertical growers, and average growers. Horizontal growers typically show more differential horizontal growth. Okay. This is how the growth curve is. The neural, lymphoid, they have different growth curves. So we are interested in this graph. This graph is very, very important. It shows you from the time a girl is born until the growth spurt, and then it comes down. Boy is born, growth spurt, and it comes down. Okay? It shows you the girls experience the peak velocity of growth during approximately 12 years. So if you keep it like a range, it's from 11 to 13 years. Whereas boys experience the growth velocity of 12 to 14 years. Okay? So that's why when we were in school, the girls of my class never liked me. They always liked boys who were 2 years older than me. Have you experienced this in your schooling days? You never liked boys of your class. You like the boys who are 2 years older than you. Because the maturity that they have is matching the maturity that girls at your age have it. Okay? So we always felt, why doesn't she talk to me? She always has to talk to guys who are 2 years older than me because they are maturing at the same level. The girls will reach the growth spurt earlier than the boys. Okay? If you can time it in a way that you are approaching a class 2 case before the velocity of growth spurt, that's when you can get the maximum growth correction. Okay? How do you identify when you have to approach the case? We have 2 growth markers. The first one is called cervical vertebrae maturation, or the CVM analysis. The CVM analysis is based on what you see on the cervical vertebrae, which is already there in the X-ray that we have called lateral ceph. On the cervical vertebrae, and I'll explain that in detail to you what to look for. It shows you at what stage the patient is in. Second growth marker that we have is called the hand wrist X-ray. If you take a hand wrist X-ray, it will show you at what stage the patient's growth is in. Was this taught to you before? Hand wrist X-ray and CVM? No, yes, maybe. Did I teach you this in seminar 1?
Yeah, you mentioned.
I mentioned, but how do you make a guess or how do you evaluate? Can I teach you that in detail? No. So we'll do that, yeah. Do you have a question?
Oh, no.
Okay, we'll look at that also. Okay, the more the patient grows in the vertical, the more the upper and lower teeth need to erupt and stay in occlusion. This can result in a flat curve of speed that happens in a class 3 case. Okay? Something like this. This is a vertical growing patient having vertical maxillary excess. Horizontal is what we are interested in. Okay? In class 2 division 1, you have a big overjet. Children, when they are born, they have a very small mandible because they have to feed. While they're feeding on the mother's milk, they also have to breathe. Breathing and feeding together can happen when the mandible is small. Okay, that's the natural explanation why we have small mandible. Once we are old enough, we are self-sufficient, so the mandible can grow and become bigger to close the deficiency. Okay? How do we use this in our orthodontic planning? We have to remember this one line. Differential horizontal growth can work for us in a class 2 case, but against us in a class 3 case. Okay? It's very important to understand the difference. Because in a class 3 case, you don't want the mandible to grow more. The more the mandible grows, the harder it is for you to fix the case. In a class 2 case, you want the mandible to grow more so it can correct in class 2. So, growth mechanics and positions of teeth. Two drivers determine the position of lower 6 in the mesial-distal plane. What are the two drivers? This is how the mixed dentition arrangement is. Okay? And that's the lower 6. For the lower 6 position, two things can happen. Number one, the E space. The moment the lower E is shed, the lower 6 comes forward. Right? You see this animation? The lower E occupies larger space compared to the lower 5s. Whenever the lower E sheds, the lower 6s will come forward. So the presence and absence of lower E's and when the lower E's fall will determine if the position of lower 6 will change or not. Okay? Second is your growth of mandible. As the mandible grows forward, the mandibular teeth rather than the mandible also will go forward. Are you understanding? The position of the lower 6 is influenced by two drivers. One is the E space, second is the growth of the mandible. Are you okay so far? Okay. See that? Animation helps everything. First animation was this, lower 6 came forward. Second animation is this watch. Mandible grows and mandibular teeth also goes forward. Okay? Three drivers determine the position of upper 6. Number one is the E space. When the upper E sheds, the upper 6 comes forward. Number one. Number two, when the maxilla goes forward, the maxillary molar also goes forward with it. Number three, as the mandible goes forward, it takes the maxillary teeth also along with it because of the occlusion. Do you understand this? So three drivers are involved in upper 6, two drivers are involved in lower 6. If you don't want the upper 6 to go forward, the third driver has to be managed. So you create disocclusion. It could be anything. Sometimes some flowable composites on the occlusal surface of the lower 6s can create disocclusion and help you take advantage of the differential horizontal growth. But you have to time it. You just can't put it anytime you like. You have to time it just before the growth spurt happens. So you need to see the growth markers and understand when the growth spurt is going to happen. At that time you have to create disocclusion. Okay? If you can keep the last movement from happening, the upper 6 does not come forward, thereby correcting class 2 differential horizontal growth. Let's ask ourselves the following questions. Make use of this principle. What is the range of differential horizontal growth? It could be anything, right? Or it could be 0 millimeters for some people, it could be 10 millimeters. It's a big range. When does it occur? The maximum. When does the differential horizontal growth occur? During the peak velocity of growth spurt, stage 3. Okay? Is there a difference between boys and girls? Yes. Boys will express more differential horizontal growth than the girls. How does this affect our treatment planning? It affects our treatment planning because if I'm expecting some amount of class 2 correction from differential horizontal growth, I can change my diagnosis from extraction to non-extraction. Isn't it? If I have say 5 millimeters of class 2 on a growing boy, and a growing class 2 boy has a lot of growth potential, but 5 millimeters of class 2 on a grown up adult, I can't correct non-extraction. If I do some growth management and reduce the 5 millimeters to 3 millimeters, the remaining 2 millimeters I can fix with non-extraction. Okay? So we have something called estimated growth system. How much differential horizontal growth is present in which situation? This is called differential horizontal growth. I'm not going to talk to you about class 1 because it's going to confuse you. Let's just talk about class 2 and class 3. In class 2 and class 3, girls and boys, the amount of differential horizontal growth in the estimated system is 2 millimeters for the girls, 4 millimeters for the boys. In class 3, 5 millimeters for the girls, 8 millimeters for the boys. Okay. What does this mean? Sorry? What does this mean? In a class 2 case, if I consider a girl and just add 2 millimeters growth, I am underestimating it. I say 2 millimeters, but if I get 3, 4 or 5, it's going to make my case easier. Right? In a class 3 case, I am overestimating it. I say the girl will express 5 millimeters and the boy will express 8 millimeters. They may not express 8 millimeters. If they express anything less than that, it's going to make my case easier. So in an estimated growth system, in class 2, we underestimate the growth. In class 3, overestimate. Okay? All of this information is added to your software. The moment you say patient is a growing patient, it will add growth into your software. What did Dr. Megan do? This is estimated growth system. He took about 700 patients and he traced Ceph and start Ceph and final Ceph from a non-treated patients in some study in Canada, and he did a statistics and he found out certain markers which influence the growth in the patient. If you know the widths of a patient and if you know the Megan angle for the patient, you can individualize and say, okay, this patient is going to grow that much. That's called individual growth system. This is estimated, that is a guesswork. Individual growth system, you can exactly say how much differential horizontal growth this patient is going to express. So if I already have this information before I start, isn't that going to completely change my diagnosis? Surely it will. And this is already there in your MOS software. It's not there in SmileStream. Before we could get this in SmileStream, the MOS was invented. So that project was stalled. And this is now involved into your planning. So if you have a growing patient who has class 2 and you saw the lower incisors are advancing this much, make it as a growing patient, you will see the lower incisors will not advance that much because they're expecting the growth to correct some amount of class 2. Okay? Remember, this is very, very commonly misunderstood line. When I say growth is going to correct class 2, it doesn't mean it will automatically correct. You have to do something by which the growth can correct some class 2. What do you have to do? Huh? Disocclude. Functional appliance also, it's a method to disocclude. You have to separate the third driver which influences the position of the upper 6. If you create disocclusion, molars, the lower arms go forward, the upper molar doesn't go forward with it. This can correct class 2. Okay? You have certain cases you would have seen in your practice where you debanded a case Patient went back, did not wear retainers. They came back to you 2-3 years later. You see lower crowding happens again. Delayed lower crowding. Why does delayed lower crowding occur? The old hypothesis was, as the 8s erupt, they push the 7, 6, 5, 4, 3, 2, but we spoke about that, that's not true. It's already proven to have no effect on the lower incisors. If I deband a case before the growth spurt, now my mandible has to grow, right? If the mandible grows forward, the mandibular teeth also have to go forward, right? But if there's no overjet, the upper teeth is not allowing the lower teeth to go forward. But the mandible has to go forward. What is going to happen to the lower teeth? It will go recrowding. Either lower teeth will get recrowded or upper teeth will develop spacing. Are you understanding? So you need to understand growth. You cannot deband before the growth spurt. Okay? If your patient is in stage 2 or stage 1, small little boy, everything is done, remove braces, growth spurt happens, you can experience these problems. Okay?
For both class, for only for class 3 or even for class
Deband. For class 3, we completely manage a class 3 patient different. How is it going to be different? Say my class 3 is 2 millimeters, but the growth spurt has not happened yet. And I don't know how much he's going to grow. What are these 2 millimeters now? And the mandible grows excessively and 2 becomes 6. Can you treat this patient now? No. So in class 3 cases, you start treatment only after growth spurt. You understand? What do you do until then? Until then you have to do phase 1 therapy. Phase 1 is do everything you can to reduce the problem. What's the phase 1 therapy you know in a class 3 case? Reversible headgear. I don't bond braces. I just keep using reversible headgear to make sure my maxilla stays with my mandible until the growth spurt happens. How do you know the growth spurt has happened? You will physically see the changes. For a girl, you can ask when the periods were started. For the boys, you can ask them when they started shaving. The voice changes, the shoe size changes. You can see from a boy, from a kid look, it becomes like an adult look. You can see some changes to tell you the growth spurt is over. Now the amount of class 3 I see is what I have in my hand to fix. Okay? If you say the class 3 was less earlier and plan a non-extraction treatment, if the mandible grows more, normally you may have to extract. If it grows too much, you may have to do a surgery. Till how long do boys grow? 17. Okay, 17 is when the growth is completed. The growth spurt happens at 14. So when the boys are 14, that's considered to be typically a good time to start braces in boys who are class 3. When do all permanent teeth erupt? 12. So 12 to 14, although the child has permanent teeth, still doing phase 1. Okay? Phase 2 starts only after the growth spurt is completed. Is that clear? It's different between boys and girls. Do we need to do something to influence it? Yes, we have to create disaffiliation.
When you say phase 1 for class 3, the face mask that we was told you were using it for 2 years without braces, not even before.
Yeah. Not 2 years, longer. What's the best time to start a reversible headgear? Whenever you have 6 is present. Reversible headgear is an appliance which uses elastic from the upper 6s to the headgear. Upper 6 is up to the age of 6. Up to what can you use a reversible headgear? So you can start a reversible headgear at 7 years also. But you have to keep using it until phase 2. Does it mean that the patient has to wear headgear for 7 years? No. They wear headgear and they keep coming to you every 3 months. When you see the molars are now class 1 or maybe 1 or 2 millimeters of class 2, then stop the headgear wear. Keep evaluating the patient every 3 months. Whenever you see the class 3 is developing again because of the growth of the mandible, restart the reversible headgear. So you need to keep doing this until phase 2. Okay? So much in mixed edition. Seminar 6. I will beat you with it. Okay? Everything about mixed edition is seminar 6. So the range is from -1 to 10. Sometimes they don't have differential horizontal growth at all. Sometimes they have too much. It's nice to know the limits so that we can expect. When does it occur? Now read this. This occurs just before the pubertal growth spurt. Okay? It is happening all the time, but the maximum happens during the pubertal growth spurts. Is it different for boys and girls? Yes. For girls 11 to 13 years, boys 13 to 15 years. Boys have more differential horizontal growth than girls. Class 3 growers have more differential horizontal growth than class 2 growers. So this is what I wrote for you. That's the estimated system of growth. Whenever you do a treatment planning in a class 2 case, when you treat a class 2 case, you want to treat them before the growth spurt, because the growth is going to help correct your class 2. Class 3 case, you want to treat them after the growth spurt. Okay, so you need to understand the growth and respect it actually. Sometimes you can throw your entire planning out. And this is what is a growth chart. On the growth chart, you see these numbers 1, 2, 3, 4, 5. These are your CVM analysis. CVM stage 1, stage 2, stage 3. If your CVM shows stage 3 in a girl, it shows that's the peak potential growth. If your CVM shows stage 3 in the boy, it's just before the peak potential. You see here, pisiform, sesamoid, PP1 capping union, all these are markers you see on your hand wrist X-ray. I'm going to show you where to go look for all that. Okay? In class 3 cases, you want to avoid de-hedging. This means you want to start later, after the growth spurt is complete. Okay? The timing is different for class 2 and class 3. In conclusion, in absence of phase 1, we want to start phase 2 before the growth spurt in class 2, after the growth spurt in class 2. Okay, that's the conclusive line. Rules. Never expect differential horizontal growth to treat. You have to do something to happen. Because very commonly, I've heard students in the class saying, oh hey, this guy is class 2, 2 millimeters, he's going to be a growing boy, I don't have to do anything, the growth will fix it. It doesn't fix it by itself, because once a class 2, always a class 2. You have to create this occlusion, you have to restrain maxillary growth, you have to do something by which the growth can be utilized. What you have to do is unlock the occlusion. Unlocking the occlusion can be small build-ups with composite or just orthodontic treatment. Orthodontic treatment, when you start ortho treatment, the teeth start moving. As the teeth start moving, the occlusion is disrupted. That is enough for you to express the differential horizontal. Restrain the mesial movement of upper molars. How can you restrain the mesial movement of upper molars? By using the cervical headgear, or you can sometimes use skeletal anchorage and tie it to the upper sixes. This will keep the upper sixes back. Okay, conclusions. DHGP maxilla mantle is always there. It will not influence results unless it is managed. Unlocking the illusion. Boys grow more than girls. Appears at younger age in girls than in boys. Okay? That's a summary of your course life. Every straight wire appliance disoccludes teeth, like the one we use. This is to our advantage in class 2, disadvantage in class 3. Okay? It's very, very important that you understand this. All of this are references in case you like to read some literature. You can take a picture of the slide and go to PubMed and show you everything that we're speaking about is evidence-based. Okay? So, hopefully this gives you some understanding of growth. It's very important to understand growth. Let's speak about growth markers. On your lateral cephalometric X-ray, guys look up. On the lateral cephalometric X-ray, you will see cervical vertebrae. These cervical vertebrae are numbered C1, C2, C3, C4. Okay? C1 is not visible on the X-ray. Alright? Because it doesn't have the shape. The first vertebrae you see is called C2. Like you see the number written here called C2. Then C3, C4, C5, so on. What we are interested is to look at the inferior border of these vertebrae. If you look at the inferior border of this vertebrae, the inferior border could either be flat or it could be curved. Okay? When this patient starts growing, the C2 vertebrae will be curved. Then the C3 will be curved, and then the C4 will be curved. It goes in that order. Okay? If you see only one curvature, it is stage 1. That means only C2 is curved, it's stage 1. If you see 2 curves, it's stage 2. And if you see 3 curves, it's stage 3. So stage 3 is when the inferior border of C2, C3 and C4 will have a curvature. That means that's the time the patient is at the peak velocity of growth spurt. Are you clear? On your cephalometric X-ray, you will see this vertebrae. Like this, you see the picture on the left. If you see this picture, you will see that you have a curve here, no curve here, no curve here. It is stage 1. You have curve here, but no curve here. Stage 2. Curve, curve, curve. Stage 3. Okay? Now, in stage 3, these vertebrae look like they are rectangles, isn't it? If you feel like this shape of this vertebrae from rectangle start becoming like a square, now it's like a square, it's called stage 4. After it's flat or square, it starts becoming like a tall rectangle, then it is stage 5. Okay, so it's confusing, but it is what it is. You have to know, you have to know. You have one curve, nothing here, nothing here. Stage 1. One curve, 2 curves, stage 2. One curve, 2 curves, 3 curves, stage 3. Till now, the shape of the vertebrae will be like a rectangle. Here it starts becoming like a square. Okay? One curve, 2 curves, 3 curves, but the shape is like a square. Stage 4. After that, it becomes like a tall rectangle. three curves with a tall rectangle is stage 5. Okay? If you see a cephalometric X-ray of a growing class 2 patient, you always go look at the CVM because it's there in the same X-ray. See how many curves are there. Okay? It's pretty accurate, but there's a problem in this analysis. The problem is there is always a difference of opinion in the inference. But I would say this is curved, and you would say no, there is no curve. That's the constant problem that we face. I'll say curve. Where's the curve? There's no curve. What I say, you'll say there's a curve. I said there's no curve. So you need something else along with this to confirm your clinical finding. Hence, we use another X-ray called hand wrist X-ray. Okay. On the hand wrist X-ray, you see certain markers. The presence of those markers will tell you which stage of growth the patient is in. Who is the patient for which you will advise an hand wrist X-ray? I want you to apply the thoughts that we've been speaking about for the last 30 minutes. If your patient is this many years old, I'll ask for a hand wrist X-ray. 11 years, girl, or 11 years girl, or a class 2 11-year-old girl, or a class 3 11-year-old girl. If my patient is class 2, then I have to do very aggressive phase 1, right? So before the growth spurt happens, I have to do something so the growth can fix it. So in class 2, I'm in a hurry. So any girl, nowadays I see girls are sometimes attaining puberty even at the age of 10. Have you seen? It's for some reason it's changing. They're attaining puberty fast. If somebody in the class told you girls attain puberty at 12 and you keep waiting until they are 12, but puberty happened at 10, by the time they come to you at 12, they are in the downward slope of the growth curve. Too late. Okay? This is called the calendar age is not matching the skeletal age. Calendar age is your date of birth. You can grow anytime. The skeletal age is patient is growing faster. You have something else called dental age. Dental age is at the age of 12, I should expect all permanent teeth. For some people it can also come at 10. For some people it comes at 14. If it comes at 10, it means the dental age is ahead of the calendar age. If it comes at 14, dental age is slower than the calendar age. So we have all of these differences which creates more confusion. So, to put it in a nutshell, if I have a patient who's a growing class 2, I want to do something to take help from growth. So any girl who's 9 to 10 years old or any boy who's 10 to 11 years old, in their start records, I will add a hand wrist X-ray just to see where in the growth spurt I am. If I think I have a lot of time for growth spurt, I will wait. If it looks like he's going to attain growth spurt fast, then I have to start acting early. Okay? In a class 3 patient, I have to take hand wrist after the growth spurt to know when I can start a phase 2. Isn't it? If my growth spurt is still not completed, I still don't know how much the mandible is going to grow. So in class 2, I take hand wrist early to take advantage of growth. In class 3, I take hand wrist later to understand when I can start my phase 2. Okay? Any questions about CVM? If you're finding it confusing, it's good. It's meant to be. If you don't find this confusing, that means you're sleeping.
So the girls you will check every year. If a class 2 girl,
Class 2, yeah.
it
And I'm going to explain hand wrist to you. Let me explain hand wrist to you and then we can talk. Okay? Guys, look up. I'll give you a break after this. Look up. On the hand wrist X-ray, you have the following markers. Okay? The first one is called the pisiform. Pisiform is a small bone present below the pinky finger. It's here. Is your pisiform. Okay? You will see a small bone here. It actually overlaps one of the bones present. It's called pisiform. The next bone you have to look for is your sesamoid. Sesamoid is a small T-shaped bone next to your thumb. Okay. Presence of sesamoid shows the patient is stage 3. Okay. Presence of pisiform shows the patient is stage 2. On all the long bones, you have something called the epiphysis and the diaphysis. Epiphysis is a small bone here, a flat bone. Diaphysis is your long bone. As the patient grows and matures, the epiphysis fuses to the diaphysis and becomes single bone. Okay, that's how we grow. If you see the thumb and the second phalanx of the thumb, at some stage you will see that this epiphysis, which is looking flat right now, becomes like a cap, like a beer bottle cap. Okay? When you see capping, it's called stage 4. At some stage, you will see epiphysis and diaphysis fused together. It's called union. Union is called stage 5. Okay? So the growth spurt occurs when the patient is at stage 3. Now let's look at the growth curve again. Does this make sense to you? Pisiform is corresponding to stage 2. Sesamoid comes before the peak growth velocity for boys and girls. PP1 capping. PP1 means proximal phalanx 1. Proximal phalanx is your phalanx is bone in the center. 1 is your first finger, that's your thumb. PP1 has a capping. It's called stage 4. DP3. DP3 is distal phalanx. Distal phalanx is the middle finger. Distal phalanx. If the epiphysis and diaphysis have united together, it's called stage 5. Okay? I know there's some confusion, so I have some examples for you so that you can get this very, very clear too. Okay. Ready? I'm going to show you an X-ray, and you will tell me which stage of growth this patient is. Is that a good exercise? So by the time we get through this, you'll be very thorough with it. This is like a quiz time. Go for it. Perfect. So you see pisiform here just coming in. Sesamoid is not there. So this patient is just entering stage 2. Everybody clear? Next. Stage? Do you see pisiform? Yes. Do you see sesamoid? Yes. Now you see this bone here. Does it look like a cap?
Yes.
Just about to start capping. So between stage 3 and stage 4. So if I have to do growth management, this is the time to do it. Okay? Stage 3 and stage 4. This is the time to do it. Do you see the distal phalanx here? Do you see any union? No. You can see them as two different bones. There is no union. Okay? Next. Do you see pisiform? Yes. Do you see sesamoid? Yes. Do you see capping? Yes. Do you see union? No. You can see a thin line, a radiolucent line between these two bones, not yet united. That means this patient is past stage 4. Clear? Loudly, say loudly. I'm not going to ask you to pay a fine if you're wrong. 4. So there is no capping yet. Okay, look at the capping here. That's capping. Here there's no capping yet. So stage 3. What about this? Stage 4. So there is capping here and there is still some space between these two. It's stage 4. What about this? How is it 4? I can see pisiform. The sesamoid is just beginning to appear. So stage 2. Thank you. Okay? What about this? 5. Because now I see there is no space between these two. Everything is united. So it's stage 5. What about this?
1.
I heard 3, 2, 1.
1 going to 2.
I can see pisiform. So it's stage 2. I don't see sesamoid, right? So I see this is stage 2. What about this?
2 going to 3.
That is sesamoid. Can you see sesamoid? So it is stage 3. Can you see capping? Yes. Which stage 4? Can you see union? No. So it is stage 4. What about this? There's no pisiform. So it's not even stage 2. So it's stage 1. So it is too early. And this was taken too early. Maybe a patient came to you at the age of 6 and you take a hand twist. That's how it looks. No pisiform as well. What about this? Now if you go wrong, I'm going to fine you. So please pay attention and look at it carefully. Ah, thank you. See, the moment I say I'm going to fine you, you wake up. What about this?
5. 5.
Okay, it's united, so it's 5. What about this? You can see, right? I don't know. When you can see sesamoid, how can you say 2? Sesamoid is 3. What about this?
2.
The pisiform is just beginning to appear, so it's stage 1. What about this? This is the last X-ray I have, so you have to get this right.
3.
Thank you. 3. So there is no capping, but there is sesamoid. Okay? So what you have to remember, if you find this entire thing confusing, we're all used to remembering things with the mnemonics, right? Please stop coming up. Can you remember the line? Please stop coming up. This is pisiform. This is sesamoid. This is capping. And this is union. So remember the line, please stop coming up. Okay? If you have sesamoid present in this case, but no capping, what do you expect to see on a CDM? Sesamoid. Three curves, and the shape of the vertebrae would be rectangle. Okay? So both this information together will give you a sure shot finding. This patient is now going to go through growth spurt. So now you can park all your eggs in one basket and go all in. Do you guys play poker? In poker you go all in. So this is how you get all in on the growth. Fix the class 2 patient. Okay? If your patient is class 3, what would you see on the hand wrist and the CVM to start phase 2? You want to do it after the growth spurt, isn't it? You should see on the hand wrist, you should see capping. Unionist growth is completed. Capping is after the growth spurt. So, although the patient is still going to grow, the maximum growth has already happened. You should see capping on your hand wrist, and what should you see on your CVM? Square. 3 curves, and the shape of these vertebrae must be square. See that I told you, you all will wake up as people want to grow. Is that clear? Yes.
Sorry, I understand you say that there's not the curve one is the curve and then no curve. I have a photo of a lateral side of a patient who is 15 years old boy.
Yes.
I don't know where to see the curve.
Here, you can see a curve. 1,